Manfred.
Hi.
Hi, it's so nice to see you.
Sure. Nice to see you.
So I will go straight ahead to the questions, correct?
Right.
Okay, so let me start from the following. People are discussing different types of vaccines against COVID, and the general perception among healthcare providers is that mRNA vaccines are more stronger, more effective, more resistant to changes of the strains. Is that true or not?
Thank you, Katya. I think that in general, that's probably a correct statement, but the RNA vaccines appear to be, and they certainly have shown in the trials and also in the field, to be very effective. The effectiveness is very high. But the other vaccines are providing good efficacy. At least this is some of the evidence we've seen from the Astrazeneca vaccine and the Johnson & Johnson vaccine, and probably some of the others. The Sputnik vaccine has also been reported to give good results. So for a control of the pandemic, the other vaccines, I'm sure, will be part of the arsenal. They'll be good for the control. They may give us a little less protection to the individual, but the mRNA vaccines are certainly a breakthrough in new vaccines.
And if we go back to the words effectiveness and efficacy, what's the difference between them?
You know, they're often mixed, and often the difference is not clear, but basically efficacy is what you really see in clinical trials, where the population is selected and you know, very carefully monitored. And it's kind of, in a sense, slightly artificial situation. Effectiveness really is what you see in the field once it's being used widely, and there's no selection of the participants. So that's the real difference. The difference in the number probably wouldn't be very different unless there were issues about the selection to the clinical trials. For example, clinical trials did not include pregnant women. So we would only see the efficacy or effectiveness in pregnant women in the studies that are outside of the clinical trials.
Would it be true to say that no vaccine for the moment has finished the third phase of clinical trials?
No, I think phase 3 trials, there are a number of them. The Pfizer vaccine, Moderna, Johnson & Johnson, and Astrazeneca have all passed the phase 3 trial. The Russian, the Sputnik, so there are quite a number, also the Chinese vaccine. So there are quite a few vaccines that have passed through the phase 3. They're basically on phase 4, which is post-marketing, where we actually now seeing how they behave in the community. But there are quite a few now that have gone through phase 3.
Coming back to the change of strains and mRNA, is it a big concern, for example, the Indian strain? Is it a real threat or not? And what can you say about mRNA vaccine and new strains of the coronavirus?
The new strains, as I just mentioned, and I'm guessing most of the people start to understand, that just means that there's been a genetic change in the virus, and it could be a very small one. These are RNA viruses which replicate and then they make changes. And so your antibodies that you get from the original strain in the vaccine may not cover entirely the new strains. At the moment, they seem to cover most of the new strains. The mRNA ones seem to be most effective. There's a slight reduction, but still effective. So as long as there's not a very dramatic change, that's not a problem. And the one last thing is that certainly with the mRNA vaccines, it's actually quite easy now to create new vaccines against new strains. You can do that very quickly with the mRNA vaccine.
So basically, if some totally new strain appears with this technology, the producers can start quickly and produce quickly, right?
Right. They just need the genetic makeup of the new strain, and virtually within weeks, they can start producing new vaccine.
People in Ukraine are massively checking antibodies. First discussion is they are checking antibodies to COVID, like immunoglobulins M and G, and discussing how protected they are, which in my personal opinion doesn't make much sense, to be honest. Does it make sense to you? And as well, the next question, that people are checking antibodies after being vaccinated. So does it make sense or not?
Yeah, it's not entirely without sense, because if you do have antibodies, you clearly, that's an indication that you've been exposed or you've got the vaccine, and then you're much more likely to be protected. There's just the main issue is what happens if you don't have antibodies. And as we know, people who get the illness, many of them lose the antibodies, or at least lose detectable antibodies after a period of time, maybe a month or couple of months. And that doesn't mean they're not protected, because the protection could be at the cellular level, what we call the T cells. And so they may still be protected, and probably most of them are. So those, if you don't have antibodies and you've been sick, you may well be protected. There's a good chance, a high probability you're protected. And similarly for the vaccines, some people may not develop a very strong antibody response and at some stage lose the antibodies, but still show a very rapid response when they're exposed to the virus. So you know, we shouldn't be too concerned if you don't have antibodies. If you do, it's, I guess, a little bit more reassuring.
If you check antibodies, are those the same antibodies? Because people keep mentioning the antibodies to spike antigen.
Right, well, there are two. The S antibody, the one that you get just to the spike protein, which is in the vaccine, is selected, and you get a different or an additional antibody response if you're exposed to the virus itself, in other words. So we can detect who has antibodies as a result of exposure to the infection, and those who actually got antibodies from the vaccine. It's very similar to the Hepatitis B vaccine, by the way. You can distinguish between people who got their antibodies from the vaccine and those who got it because they were actually exposed to the virus.
If we go to, for example, Astrazeneca vaccine or Covishield, Indian Astrazeneca, which is used in Ukraine mainly, and apart from that vaccine as well, there is a small amount of Pfizer, and apart from that, there is a small amount of Sinovac being used. But the more questions people are asking after AstraZeneca or Covishield vaccine, we checked our spike protein antibodies, and we do not see the antibodies after the first dose, after the 2 or 3 months. Should we be worried and turn to mRNA vaccine, or should we continue with the same vaccine and disregard the fact that we don't have the antibodies?
Right. It's quite possible that after the first dose, there's not a strong antibody response, and you may not have detectable antibodies. And the protection we know, both for the AstraZeneca and even for the mRNA vaccines after the first dose, is not 100%, a lot lower than 100%. So I would certainly see no problem getting the second AstraZeneca vaccine to boost your antibodies. It's just important to remember to get the second dose.
Coming back to the products, to the different vaccines, what is the global trend now? Which other candidates and of which technologies are expected in the market? Or that's it, and basically we are only expecting existing candidates to be registered, not for emergency use, but just in general pre-qualified by WHO or something? Or are we expecting some new technology?
You know, I guess for many reasons, because of the pandemic being so large and as a result, so much money being invested to try and control the pandemic, I think that there are now more than 200 vaccines have been put into development. Most of them probably will never reach the stage where they'll be used. So you may see some newer vaccines coming in. But I think that we have now a wide variety of vaccines. I'm not sure that we need any more, although it's always nice to have a more effective vaccine. The one problem with the mRNA vaccines, as you know, is the storage and the transport, because it has to be very low temperatures and the dilution and so on. So that has to be improved. The AstraZeneca one is much easier to supply and actually put into the field. So I think the future will be on very effective vaccine, maybe improving the mRNA vaccines so that they're easier to transport and don't require very low temperatures.
What about non-responders? Do we know anything that there are a lot of complete non-responders to the vaccine or not yet?
I think we're still looking at it, but that wouldn't be surprising. We see that in many vaccines. The most common one that we know of, because it's checked, is the Hepatitis B vaccine, where you get a percentage of people who just don't respond. And part of it is a genetic non-response mechanism, and we know some of the genetic makeup of people who don't respond as part of the immune system. And in hepatitis B, for example, one of the ways in which we do it is we give them another series. So we give them 3 doses and then we give them another 3 doses. But there are some who are very resistant. I'm not sure how common that will be with the coronavirus, with COVID-19. So we'll wait and see. At the moment, it seems that the response rate is very high. Most people who develop in the trials, everybody seems to have developed antibodies.
If we speak about the trends within the schedule, what do you think it will be? 1 dose, 2 doses, 3 doses, and the revaccination? What are the trends of the discussions between mRNA and other vaccines?
Yeah, it's interesting. It largely depends on the objective, and this has been a major discussion, and I guess it might be a discussion in Ukraine. Because if you actually give 1 dose, you get partial protection. And that may be, so the argument would be, let's have more people getting 1 dose if we have a shortage of vaccine than to have fewer people getting 2 doses. So there is some sense in saying, let's give as many people as possible the 1 dose. And then at a later stage, give them a 2nd dose. There doesn't seem to be any problem waiting a few weeks and sometimes a few months to give the 2nd dose. In fact, for vaccines, we generally don't have an upper limit. We can usually give them pretty much a long time after the 1st dose. But I would say certainly 3 to 6 months after the 1st dose, you would still get a good response from the 2nd dose.
It doesn't matter whether it's RNA vaccine or any other vaccine.
Yeah, I think that most of them would behave pretty much in the same way, but you're right. It may depend on your response. So if you get a very strong response on the 1st dose, clearly it's probably going to be easier to wait much longer. And the Astrazeneca is based also on on a viral vector. The one vaccine, and I'm not sure if that's the Sinovac, is that the inactivated vaccine? I think it's the inactivated viral vaccine. So inactive vaccines, sometimes if you wait too long, maybe you'll get a lesser of a response. Although for hepatitis A, for example, which is a simple inactivated vaccine, from 1 dose, you get very good protection. And you can wait quite a long time for the 2nd dose. You can wait virtually for a year.
You said 1 dose partial protection. When the person can expect to be at least partially protected after the 1st dose, when the effect come?
Usually we expect to see some protection about 2 weeks after the 1st dose, or after any dose, your immune system will actually respond adequately after about 2 weeks. So we usually say 2 weeks. It's a guide. It may be a little bit before and maybe slightly after, but 2 weeks is a good guide.
And when we say partially protected, we mean just general protection, that the person will not die of COVID and will not go to the ICU department and will not need oxygen support?
That's a very good point. I think partially protected can be seen in a different form. The one would be that it prevents disease totally, and that may be quite low after 1 dose, let's say 40, 50%, but you may be much better protected against severe disease. So in fact, that's true, that in fact, partial protection might imply that you may still get the disease, but you will get the milder form of the disease. So there's some good aspects of being partially protected.
What is the discussion globally now with regard booster dose? When the booster dose will be needed, or if it will at all be needed?
Yeah, that's a controversial issue, and I'm not sure. I'm in a camp that is not convinced that we'll need a booster dose for quite some time, but there is certainly a strong camp for campaigning virtually to give a booster dose early on, sometimes 6 months or a year after you've completed 2 doses. I think we still need to learn more about that. I'm not entirely convinced that we'll need a booster dose so early, but again, we're learning. So it's going to take us, I certainly feel that to give a booster dose in less than a year after the COVID, it doesn't seem to make sense. I know there've been some who were pushing even for 6 months. I'm not convinced. But again,
and what is the rule in Israel now? How this certificate, vaccination certificate or Darkon Yarok, when does it expire? Within half year or?
Well, no, right. So we haven't really made a final decision, but we've extended the Darkon Yarok, the green passport, and that will be for the end of the year. So it means that for myself, for example, who was vaccinated in December, I will be, or January maybe, I will be have that certificate until the end of the year. In other words, for 1 year. But and I think that's going to be revised again. So at the moment, it's for 1 year.
Did you receive both doses of the vaccine?
Right. Yeah, I received both.
You did. Mm-hmm. Yeah. How did you survive the vaccination?
I virtually had no side effects. I mean, I had a little bit of pain in my arm, but otherwise I felt fine. And I can mention Dorit, who you know well, Dr. Dorit Nitzan from WHO, and she had both doses, and she had some fever after the first dose, actually a few days after, so it was a little unusual. But for the second dose, she had no side effects at all.
Mm-hmm. What with regard the concept that the vaccine will reduce the spread of virus, making people less contagious, do we have any proof of that or not yet?
It's still under study, but I again would say that I'm in the camp which would say I believe it is preventing the spread. And the reason I'd say that as well is that the numbers in Israel have dropped dramatically, and we've vaccinated about 80% of the eligible population, but we haven't vaccinated children up to the age of 16. So that's another 1.5 million and another million. So there's still about 3 million people or more who haven't been vaccinated. And there's no longer really any spread of the virus, or virtually none. I mean, yesterday I saw there were maybe 30 cases in the country. And these are cases that were infected a couple of weeks ago, I guess. So, and that's dropped from thousands of cases. So there's virtually no spread at the moment. And I think that indicates also that the vaccinated people are not spreading the virus, because I would have expected personally that there would be much more spread from vaccinated people if they were still carrying the virus, because we still have a large number of people who are not vaccinated or not immune. So that's my guess. But I know that the current thinking is that we still don't have really solid information. It's still being studied. The tendency, I think, is to say it is preventing it, and it makes sense. I mean, this happens with a lot of diseases. We know this with measles, mumps, rubella, and so on. Generally, these people don't basically, you may carry the virus for a short time, but I don't think it's an important enough one for spreading the disease.
We see a lot of effort from all over the world with regard to solidarity clinical trials due to pandemic. So do you think there is any perspective in the treatment of corona, I mean the antivirals with regards to corona, or it's already the lost hope and it's basically only the vaccine and effective drugs like dexazone or blood thinners or something like that?
Right. I don't treat patients. Although I'm a physician who doesn't treat patients, I'm an epidemiologist. But I will tell you what I've learned from my colleagues and so on, and what I've seen. I think that what we've seen is a gradual reduction in mortality, in hospital mortality and mortality. And I think that's understanding better how to give supportive care to these patients and to give earlier care. I mean, the clinicians have generally said that if patients come in earlier, they have a much better chance of doing well and of surviving. And that's without really talking about any specific drug, because as you mentioned, we don't really see any dramatic effects of the drugs, but the physicians are still using some of them, and they seem to believe that it depends very much on the timing. So some of them, if you give it earlier, like dexamethasone, maybe giving earlier. Immune globulin is one which maybe if you give it earlier. So these are ones that, so it'll be very selective, but there is no single drug at the moment, the medication that's shown to be really effective.
Manfred, and with regard to recognition of vaccines, for example, Israel, when you will allow people to cross the border and enter Israel, will you recognize all the vaccines or only the vaccines which are recognized by Israel or by WHO? And the same, not only about Israel, but there is the whole debate with regard to EU and how will they allow people in. What do you think about that? How can you comment on that?
Right, there hasn't been a real decision on that, and it's a discussion, but I would think that the tendency would be to recognize by WHO. So the vaccines that have been approved by WHO will be, I believe, the ones that we'll recognize. There may be some bilateral agreements if there is some interest in recognizing other vaccines, but I think that will be, it'll be combined with testing. So I think that's going to be the thing, that people who come into the country, if you tested before you leave the country and you tested when you come in, that's also going to be an important factor. But at the moment, I think it'll be really the vaccines recognized by WHO, by the World Health Organization.
And do I understand correct that it makes sense, the whole vaccination certificates or passport, only if we will have the proof that the vaccine makes people less contagious or not?
Well, I think we now feel that if someone's vaccinated, I think they are not going to get infected, and the chances of them spreading the virus are very low, and particularly if they've been protected. I think the big issue with vaccine certificates is to make sure that they are secure documents and there's not counterfeiting and there's not falsifying documentation. So that's going to be a very strong international effort to make sure that people are not, buying false certificates. We hope that
because
won't
in my opinion, this effort makes sense for two reasons. One is if we are sure that people are not spreading if they are vaccinated. And the second, that it will generally motivate and boost people to go and get vaccinated finally because they want to travel.
Yeah. Sure.
But is there anything else to this or not?
No, I think that's a very good point. I think, it's just like we had people, maybe the older people like us, remember smallpox vaccination, where you couldn't travel without showing that you'd been vaccinated against smallpox. And there's some countries against yellow fever and so on. So, I think that that's a good way of motivating people to get vaccinated. And it's an important issue. So I hope that this will be part of the campaign.
Before I continue with my questions, I will give you the questions from the audience, because we are listened by the audience and they are asking questions. So one of the questions is related to the efficacy and effectiveness. Tatiana is writing to us, my friend who lived in Moscow was vaccinated with Sputnik 2 doses and got infected with COVID-19 in 10 days after vaccination. She died in the hospital on April 12th. Can we comment this as a non-responder, or there can be other reasons why a vaccinated person can die of COVID if the person was vaccinated with 2 doses?
Right. Well, as we say, you really only get to optimal immunity at least 2 weeks after the second dose. So, this can happen that people are infected before then. I'm assuming she knows she was infected on 10 days after the second dose, or not, because she may well possibly have been infected before. And it means personally, but we know that the vaccines, even if the vaccine is very good, there's still a small percentage who do not get protected. I guess you could call that non-response. I mean, that makes sense. It's difficult. We haven't really defined non-responders, but even the best, even the mRNA vaccines give like 95% protection, 94%. So there's 6% or so who are not protected. So unfortunately, there'll still be cases. As long as the virus is around, there's still going to be people, even those vaccinated, who will get sick. By the way, I'm sure everyone knows that for measles and so on, we still see cases of measles in people who are vaccinated when we have epidemics. So it's basically a control at the population level.
Lyudmila Medvedeva is telling me that this information is not watched only by the specialists and doctors. So what are the mRNA vaccines? mRNA vaccines are Pfizer and Moderna currently. Are there any other mRNA vaccines?
I don't know the names of the companies, but there are other companies working on them. And I'm sure there'll be many, because it's a technology now that I think will be adopted in many fields. But I do believe.
But for the moment, it's only 2 products, correct?
The only ones I know of that are actually in the market are Pfizer and Moderna. Yeah.
Mm-hmm. And Oleg is writing to us that vaccination is pushing the mutations and appearance of the new strains of coronavirus. Is that true or not?
You know, it's a very good question. And that really is a question when you're not vaccinating enough people. In other words, you're only vaccinating half or a third and so on. And then the virus is circulating widely. And I guess there could be some pressure, in other words, to mutate. So basically, the way to deal with that is to really get very high vaccination rates. And this is one of the reasons why we really believe that the vaccination rates have to, it's not just herd immunity, but it's, you know, even above that. So it's 80%, 90% would be good. So we really have to make sure that a very high percentage of the population is vaccinated. And that is, when you get low vaccination rates, then I guess it's more inclined to be a field for mutations, basically.
So would it be correct to say that the higher the coverage is, the lower the risk of mutation is?
Oh, certainly, yeah. Yeah.
Would be cool.
Yeah.
What happened to influenza? Did it disappear all over the world for this season?
Very interesting question. Where has it gone? Where is it hiding? It's true that the interventions used for COVID were very effective for influenza. Influenza is less infective than COVID and easier in a sense to protect. So I think we need to think about it. There are people saying that now during the winter months, we should encourage people to wear masks and have more social distancing and a little bit less crowding. And that will prevent influenza. As we know, there are many deaths from influenza each year. And it can be a severe disease. But it does seem that that's happened. There is one theory, though, that I'll mention, that Dorita's mentioned it to me, and that is that the virus may be, there is some concept where viruses displace other viruses. So in other words, while the COVID virus is around, it's actually displacing the influenza, and the influenza virus has more difficulty infecting people who have been infected with COVID. It's a possibility. It's a possibility. But I'm hoping that it's also by the way, it's not just influenza, as you know, it's RSV, respiratory syncytial virus, other viruses that drop dramatically, almost, you know, disappear. We have to see now whether influenza will start recurring and where. So I guess we're waiting for the winter months in the south.
For you, as for the specialist in the public health, and for the person who worked in tons of different groups, technical groups on this and on that with different scientists, what are the big changes in public health due to this pandemic?
I think that there's several things. First of all, clearly we were not well prepared for the pandemic. So I think that we need to recognize that we need to strengthen the public health services so that they are much better prepared. Better prepared for actually tracing contacts and doing epidemiologic investigation and putting good data together. The other thing, and that is the area of sharing of data, that we've learned now more to share more data, and we need to do it much more. Collect good information and share that information. And that's the key to actually controlling any kind of outbreak. I mean, the lack of information was one of the problems initially. We didn't know how many people had been infected, where they'd been infected, how long they were sick for. There were a lot of gaps, and that's very important. And I think that's going to help public health in general. And one last thing, it's encouraged people to come and specialize in public health. We've had a very big increase in interest in public health, in taking
Do you
public
see
health
more
exams.
students for public health in Israel for that
Right,
program?
yeah, we've had a big increase in students wanting to study for the Master of Public Health program.
Interesting.
Right.
If we go to the question with regard children, as I understand, there is a Pfizer approval by FDA to use it for children from 12, correct?
Right.
And Israel is planning to vaccinate children.
There has not been a final decision, but there will be discussions on it. And there is, I think, a tendency to decide that they will vaccinate children. It's obviously one of the more difficult areas because, as we know, the disease has been pretty mild in children, often asymptomatic. But we need to probably vaccinate children to get good herd immunity. I would stick my neck out and say that I would maybe like to see a little bit more data on using maybe lower doses in children. I'm not sure that we should be using the same dose. I maybe shouldn't say this in public because that'll create uncertainty, but that's certainly my feeling. So I would like to see a couple of studies using lower doses in children, but I don't know that whether that's planned at all. Maybe we can do something together.
Tell me, do you think it will be easy to vaccinate children? Will parents go for it? Will children themselves? Because 12 years old, it's pretty kind of old child. I mean, not old, but how can you say, like mature personality. So would it be easy or not?
I think it's not going to be that easy. That you need the parents to be very much involved. They have to be very much aware of the benefits. Part of it is where they can travel with their children without the children having to be tested all the time. So that's an incentive. And I think we have to make it clear that there is a benefit to the child, and also there are serious cases in children. I mean, it's not that that all cases are mild. And we know there are these autoimmune cases that have occurred in children from COVID. So the vaccine, I think, looks very good for children. But it's going to be, as you say, I think we're going to have to do a lot of public relations to make sure that the public are aware of the importance of the vaccine.
What's going on globally with the vaccination of pregnant women? Is it only mRNA vaccines being used for pregnant women or other vaccines as well? How safe it is? And what can you say
essentially, if it's not a live vaccine, then there's no real issue. Generally, it's vaccinating pregnant women, and the disease in pregnant women does seem to be much more serious than in non-pregnant women, as it is for influenza. So we recommend vaccinating pregnant women, but they're pretty much not really live virus vaccines, although there are these non-replicating viruses that are some of them, I think. So, certainly for the mRNA vaccines, we've had no issues with pregnant women, and we strongly recommend it.
Is the coverage good in Israel for pregnant women for the moment?
It's become, much higher, right? It's pretty good.
Can you say any figures? Because as you know, in Ukraine, it's a huge issue.
I don't know the actual percentage, but it certainly started off very slowly, but it increased rapidly. So I think it's very high. I mean, it's pretty high now.
So it's not like 10% or 5%, it's more than that.
No, I think it's probably more than 50%, yeah.
Is the attitude of healthcare providers in Israel to this vaccination good or not? Because in some countries, including Ukraine, this is an issue, this is a problem.
Excuse me. No, I think that generally the healthcare workers are very much in favor of the vaccine. There are very, very few that are really hesitant about the vaccine. So I would say in general, the medical community has been in favor of the vaccine. There may be discussions again now about children, And that's becoming an issue. And there are some now saying they're not sure that children should be vaccinated, but that's a minority. That's a very small group at the moment.
What would you say about the older people? Because there is as well a debate in Ukraine that if the person is, for example, 80 plus or 90 plus, the vaccine will not be efficient.
Well, that's true about many vaccines, that it's less, less immunogenic. In other words, less likely to produce an antibody response. But from our data, you can see the mortality, for example, in the elderly drop dramatically. I mean, we're now at 0 deaths. You may argue that that's because it's not spread very widely, but it does seem that the elderly people are very well protected. And so
with the vaccine.
Yeah, they're not getting infected at the moment.
There is a big debate in Ukraine with regard to the vaccination of those who were sick with COVID. Right. The essence of this debate is really very strange because some professors came up and said that if you are vaccinated after being sick with COVID or after having antibodies to COVID, that would make bad for you and you will have some cytokine storm or some kind of reaction and that it's too dangerous for you. Is that true or not?
We haven't seen any problems. Again, we're still in early days, and I don't know how many of the people who've been sick with COVID have been vaccinated. These are recommendations. So our recommendation is to give them 1 dose. And
but not because of the danger, because of efficacy or because of the danger.
Right, but we haven't seen any major side effects. I can't give you a number of how many we vaccinated, but it is a general recommendation right now. It doesn't seem to be an issue, but again, we monitor this and we haven't yet seen anything that's problematic. Certainly in the data we have on side effects of vaccines, we haven't seen specific side effects in people who were vaccinated after they were sick. But again, we still, I don't think we've vaccinated many people because that's really just started recently. So we need to monitor it, but we're not particularly concerned at this stage.
And theoretically, from the immunological point of view, can there be any danger or not?
I doubt it very much, because if you think about it, just about with other infectious disease or viral disease particularly, if you've been infected and then you get reinfected, you basically are protected. I mean, giving the vaccine is not too different from being exposed to the virus. So why would you see something different with the vaccine? So it would almost say that if you've been vaccinated, it's dangerous to get the disease. That doesn't really make sense. There is, I think that's pretty much what I would say. I don't see that as an issue, at least.
What is the safety profile in general? What do you see? For example, initially, people were very concerned that there will be very severe allergic reactions. Did you see a lot of allergic reactions? And what is the general safety profile of, for example, Pfizer, which is used in Israel?
The allergic, we haven't really seen, we've seen allergic reactions. Fortunately, they've all been treatable. In other words, there have been some cases of anaphylaxis shock, but they recovered very quickly. So there's been nothing dramatic about that. We are, though, and it's been reported, we are studying now possible myocarditis after the vaccine. It's not clear whether it's associated, because myocarditis is fairly common in the population. And we're seeing the same pattern of young males basically being more affected. But most of the time, the side effects can be uncomfortable. I mean, people will tell you a few days they can feel bad, they can feel tired, they can have fever. So I'm not saying there's none. There's certainly a certain percentage of the population have had side effects that are very uncomfortable. But on one study we did in people in the workplace, there was a fairly high reporting of side effects, but none of them recorded missing work because of the side effects. In other words, none of the side effects were bad enough not to go to work. So in other words, would feel uncomfortable for a couple of days, but that was it.
With regard to the famous big discussion of thrombosis, is there a final verdict? Is thrombosis caused by any of the vaccines, mRNA or non-mRNA or vector vaccines or any vaccines? And if yes, then how this thrombosis, if those could be prophylactic somehow? The reason why I'm asking is that this debate is huge in Ukraine. It's everywhere in the news. And unfortunately, it immediately resulted in the practice for the primary health care and other physicians giving patients blood thinners before the vaccination for 5 days or for 7 days.
Right.
So what's your opinion on that?
I think that you actually know much more about this than I do, but the Astrazeneca one certainly has had some association with some what they've called thrombocytopenic thrombotic events, which sounds like a contradiction. What has happened is it's pretty rare, but it does seem to occur occasionally. Occurs more commonly in women, in younger women. It's still rare though. So compared with getting COVID, it's still better to get the vaccine. My understanding, and again, is that in fact, you should not, in fact, even the treatment of these patients, you should not be giving something like heparin, for example, because it's a more complex way of it's the so-called thrombocytopenic thrombosis, which is complex. So I really don't know enough about it, but my understanding would be that I've not heard of people giving any kind of prophylaxis. I would certainly not think of that as a good idea.
Okay, there are lots of questions, and there is one question and statement from Evgenia, who is watching us right now, that the vaccines against COVID are somehow affecting the reproductive function. Usually this was rotated about the HPV vaccines as well, but now it's widely rotated in the social networks with regard to COVID vaccine. So does COVID as an infection or COVID vaccine affect reproductive system?
Right, we've heard about this, and this is very much in the social media. We heard it, by the way, with polio vaccine. I don't know if you remember in Africa. You have to remember that for some reason, this kind of news is often propagated for political reasons. And for example, with polio, there was a kind of a news that was spread in Nigeria, for example, that the vaccine supplied by the West was being used to control the birth rate in Nigeria. So they believed that there was something in the vaccine that affected reproduction. For the COVID vaccines, there's no evidence that it can affect the reproductive system. The COVID-19 itself, the infection it can affect temporarily reproduction, but mainly in males, as I understand. But that's the infection with the virus, where the actual virus causes infection. This vaccine doesn't cause any infection. It doesn't have any kind of active virus in it. So biologically, there doesn't seem to be any mechanism whereby it could affect the reproductive system. So I would be very skeptical. I don't think there's any scientific evidence to support that at all.
There is a question from Tatiana. I am reading it as it was written by Tatiana. We know that a cytokine storm is a serious complication of COVID-19 disease. Is it necessary for all people to track some blood markers to avoid development of the cytokine storm? Or perhaps these markers should be tracked only by people with coronavirus symptoms?
Yeah, I don't know. That would be in a kind of a clinical area, which I'm not familiar with. It doesn't seem to me to make sense. But again, I would say that we need to talk to more clinicians. I haven't heard about that at all. So are they talking about people who are healthy? In other words, who've not suffered from COVID and basically would be evaluated beforehand? I don't think there's any evidence that helps in any way.
You are a member, I guess, of different COVID groups in Israel, are you?
Yes, I'm on the...
Which ones?
I'm on the National Immunization Committee. And then there are two other committees. There's a National Committee for the Control of Epidemics, where we deal with COVID. And then there's a subgroup specifically on the COVID vaccine, where I'm in that group. And I'm in another small group, couple of groups on evaluating side effects and the efficacy of the vaccines. These are all national committees.
What can you say with regard to the success of Israel in immunization for the moment? Do you evaluate what happened as a success or not? And if yes, then why? How many people are vaccinated with 2 doses? Are you happy with the risk groups coverage? Can you say something about this in figures or without figures?
Right. Well, no doubt it's been successful because, as we said, the rates have dropped dramatically. We virtually see no COVID-19 now, and probably half of them are imported if they manage to get through. So the vaccine has been amazingly successful, I believe. That was partly because Israel very early on took out options and paid basically for options to get access to vaccine. So we had access to vaccine early on. And we managed to receive enough vaccine to cover the whole population. So a very high percentage of the population has been vaccinated. More than 5 million, the population of Israel is 9 million, about 9 million, and more than 5 million have been vaccinated. And so if you take out the children up to the age of 16, which is probably close to 2 million, so that leaves basically out of the, more than 5 out of 7. So we're close to 80% of the eligible group who've been vaccinated. And some of those have also been sick, so they may not be vaccinated because they actually got COVID. We had about 500,000 cases of COVID in Israel, diagnosed, of course. So basically, we have very high immunity in the over 16. Under 16, it's only those who've been actually infected. So it does seem to be very successful. Where it was very problematic was in subgroups which were in areas where they lived in very cramped environments. In other words, there was a lot of overcrowding. Many children, and you probably wouldn't even believe it, but there are families or subgroups in Israel who have 10 or 12 children. And so you can imagine there's a lot of crowding, and there was a lot of disease in that group. And there was some problem immunizing them, but in the end, the immunization rates in those groups went up a lot. We still have some groups who are under-vaccinated. The young, between, let's say, the age of like 16 to 35, are less vaccinated. They still maybe just less belief in the usefulness of the vaccine. So we still need to work on that group. But by and large, it's been very successful.
How would you explain this success? Why are you so successful with that? What helped?
Well, first of all, we have a national health service which everybody is covered by national health. So basically all your health needs are covered by this insurance. And then we have a very big network of clinics. We have what we call health. They are kind of HMOs, health maintenance organizations. So we have 4 in Israel, and you have to belong to one of them. And they are responsible basically for your health needs. And they actually also keep track of you. So these clinics, my organizations will actually be sending messages to you that you need to be vaccinated. They would tell you where to go, at what date. You could actually choose the date and so on. So it was very easy to get vaccinated. I was talking just about the vaccination, but it also helped with the tracing and contact. The hospital services are also good in Israel. I'd say very good. So we have a high quality hospital care as well. So people who got sick got good quality care. That doesn't mean that it didn't have an impact. We had 6,000 people who died from COVID. So it's not, we can't neglect that there was an impact. And there were outbreaks in the care homes, old age homes, where people or nursing homes where a lot of elderly people got sick, and a lot of the mortality initially was from there. So those were not so good. But generally, because we have this very centralized health system, which is very accessible, wherever you live, you're very close to a clinic, and it's easy basically to get to a vaccine center. And I guess the population in that sense is still compliant. In other words, they adhere to the recommendations. Our vaccination rates generally are very high in Israel.
Irina is asking us if you should give the drugs which are reducing temperature if you have temperature after the vaccine.
After the vaccine, there's no problem in giving paracetamol.
Antipyretics, you can?
Pardon?
You can give antipyretics after.
Oh yeah, after the vaccine, there's no problem. There were some who were even recommending giving before, but that doesn't seem to make sense. There's no need to generally to give before, but afterwards, sure. If you have fever, you can use acetaminophen, and some of them say you can give the ibuprofen. So those antipyretics are fine. At least there's no evidence that, as far as I know, that should cause any ill effect. It's just like anything else.
Is asking us if it is possible to get vaccinated if the thyroid gland is removed.
Yeah, that I think they would have to consult with their own physician, but as far as I know, that's not a contraindication, but that's always something to consult with the physician. I don't see any reason why not, and in fact, it probably makes sense to get the vaccine to make sure you don't get the disease.
Julia is sharing with us information that in Kiev, doctors are recommending blood thinners after vaccination for 30 days.
I haven't heard about that. I would need to see evidence on that. I have not seen any evidence on that's effective. And my feeling is that it could also be dangerous. So I don't really know what's been done. I think, to give people routinely blood thinners, I don't know what kind of blood thinners they're talking about, Coumadin or warfarin or whatever, or you're talking about aspirin or something. But I don't see it. You're talking about doing it for the Astrazeneca vaccine, I guess. But as I said, the Astrazeneca vaccine, as I said, the mechanism is complex. So those that have that thrombocytopenic thrombotic event. So I've not heard of any recommendation like that, but that needs to be checked. And I would ask you as well. You could tell me.
Yaso is asking us, I will try to translate in a correct way. How did it happen that antibody-dependent enhancement of the infection due to vaccination in dengue, and that children would die after they would encounter the virus? Why the same cannot happen with the coronavirus?
Right, that's true that there have been reports that the dengue can do that. Although, as I understand in the reports that I read on dengue, that's not being conclusive. I mean, it's not very clear what is actually happening with dengue, and it's apparently a pretty rare event. But there is no evidence that the coronavirus behaves in that way. Remembering, again, that the coronavirus is from another family, and we have coronavirus all the time. Coronaviruses cause common cold and all the rest of it. So it's a well-known virus, and I don't think that there's any, and I don't think we've seen it at all. And if you imagine now that millions of people have been sick and millions of people have been vaccinated, and there's still a lot of virus around. I mean, if you take a country like the UK, for example, where half the population have been vaccinated, and there's still a lot of virus going around there, I have not heard of any case of ADE there. So I think you could say it virtually for any disease, but I don't think there's. Dengue is the only one that I know of where it's been reported as being a possible correction.
If you are looking at different things in Israel at the global level, at the EU and from WHO perspective, What is the main messaging you would now give to the healthcare providers with regard to the pandemic and with regard to the immunization against COVID?
You know, the advice generally, it's not surprising, is that we cannot really control pandemics without a vaccine. And when I say can't control, we can allow the pandemic to run its course and get millions of deaths. If you look at the death rate from COVID-19 now, and you compare it with 1918, with the influenza pandemic, it's actually not that different. It's just that we have much better healthcare. But if you look at the numbers, without our better healthcare and without a vaccine, we probably would have got to the stage what we'd seen with the pandemic flu in 1918. That's my feeling. So basically, the vaccine here is an essential tool to control the pandemic, and it's been very successfully used. That doesn't mean that there are not side effects. So you remember, the vaccine is not a magical cure. There'll be side effects, there'll be failures. But for the control of the pandemic, for us to get to living a normal life, we need to basically vaccinate as many people in the world as possible. As long as there are pockets
of this.
Sorry?
What is the perspective of this? When do you think the pandemic will be under control?
You know, the WHO uses that expression, nobody is safe until everybody is safe. And basically, in Israel, for example, there is this semi-euphoria. But, you know, Israel is an island in the world. And as long as there are big countries and populations who are not immune and haven't been immunized, that's going to expose your local population. So really, we're going to have huge challenges in Africa and Asia to make sure that the populations there are vaccinated, and also in Europe. So, you know,
is it a question of years?
It depends very much. The vaccine companies claim that they can produce now billions of doses. So basically get large parts of the world vaccinated. I think the problem will be vaccine hesitancy, people not wanting to get vaccinated, which will be an issue. And I hope we can overcome that. And then I think that we can do it in much less. You know, I know that it's a challenge for a country like Ukraine, but I think that if Ukraine had a good vaccination campaign, and I'm not sure what your access is to vaccines, but I'm hoping that you will get good access to vaccines. You could get the rates down very dramatically. And then basically, you know, we're now in a situation where you can go wherever you want. You wear a mask where you go into closed places, and even that they're talking about maybe reducing. You're allowed gatherings and so on. And so, you know, we can get back to that. And that's now. So you may have to be able to tell me what's happening in Ukraine. I'm not sure what the vaccination rates are there.
Some questions from our audience. The question from Lydia: if the first vaccination you have the reaction, will the second one be worse, the same, easier? I think it's about more of vaccines type Astrazeneca, Covishield.
You know, to be honest, it doesn't seem that if you had a reaction in the first, you would have a worse one in the second. And again, on just personal people I don't hear about, but there is evidence that after the second dose, there are more reactions. So that we need to recognize that the second dose does seem to be more reactogenic. And that's probably because of your immune response, because your immune response is stronger to the second dose. Usually, again, they're not major problems, but that can happen. But it doesn't seem to be okay. But we do say, for example, if someone has had anaphylaxis with the first dose, then we would not give the second dose. So, you know,
is the only contraindication, basically?
Although, yeah, it would have to be quite extreme. Although, as you say, you can give it under controlled conditions. So it doesn't have to be an absolute contraindication.
Tatiana is asking, there is an information with regard to the vaccine which is supposed to come in the end of the year. It's called Valneva, and it's by Austrian-French manufacturing. Do you know anything about that?
No, I've heard about it in being in development. I'm not sure that it's I'm trying to remember which technology they use. Are they using, it may be one of the companies who's also now going into mRNA vaccines. I'm not sure. But it's just another company, yeah.
Another Tatiana Talochka is saying, I am a doctor from ICU. I had COVID. When should I be vaccinated, and which vaccine is better for me, vector vaccine or mRNA vaccine?
First of all, I understand, this is again, a general recommendation is usually around about 3 months. You should wait about 3 months before you get vaccinated, if at all. And again, there doesn't seem to be any evidence that one vaccine is better than the other in people who've already been infected. So maybe, but I haven't seen any studies on that. But it seems to me that biologically it doesn't seem to make much difference. You know, I think if you're getting stimulated by the antigen and you've already been, you know, you already had the illness, you probably will get a very good antibody response.
But this 3 months, because this is one of the biggest issues in discussion in Ukraine, is this 3 months related to the safety of the vaccine to those who were sick before, to the efficacy, or for other reasons?
I think the main reason is the so-called reactogenicity, because in a sense, you're getting, it's like the third dose, it's like virtually the booster dose. So I think that it's basically a time for the body basically to recover, and that your immune system is worked back to normal basically. And I think that's pretty much, it's a rule of thumb. I mean, it's not really something based on some kind of scientific data. It's approximately 3 months. I mean, it'd probably make no difference if it was 2 months or 4 months, but 3 months has just been chosen as kind of an arbitrary number. But I think it's more for the side effects than the efficacy, although it's also for protection. So you don't give it too early because there may be more side effects, but you want people to be protected, so you don't want to wait too long. That would be the guiding principle. So 3 months seems to be a reasonable time.
And another question which quite often people are asking me, and when my colleagues learned that I will go into the interview with you and you were teaching in all different schools and conferences in Ukraine, so they deliberately told me to ask you the question like this. If you have the vaccination of Astrazeneca, but somehow you are not, for example, sure if you are fully protected or not, what will happen to you if you will vaccinate on top with Pfizer or Moderna? I mean, after the vector vaccine or any other vaccine, if you will use the mRNA vaccine, will it do any harm to you or not?
Yeah, so you're talking about someone who's had 2 doses of AstraZeneca, for example.
There are different scenarios which people asked me to ask you, but let's start with this one. The person got the 2 doses.
You know, there are very few vaccines where we would worry about giving extra doses. For example, you know, we give pertussis vaccines to women who are pregnant in every pregnancy. And even though they've been vaccinated and they have and they're immune basically. So we boost their immune response. So it doesn't seem to me that there should be any problem. You know, if you think about it again, if you've received the vaccine and you're immune, and you get another vaccine, it's not any different from being exposed to the virus, and even less so. So in other words, the virus, you're not expected to have any major response. All you do is you'll boost the immune response. So I would guess that there shouldn't be any issue with that. I mean, again, I haven't seen any specific data on that. There are so many combinations now that there'll have to be lots of different studies. Maybe we need to talk about that. Which we can do just to look at the immune response. But from a biological point of view, it doesn't seem to be that there should be any issue. There should be any problem.
Another question people ask is that if you have the first dose of, let's say, AstraZeneca or any other vaccine of this type, can you have the second dose of mRNA vaccine? Or you will have to have 2 doses of mRNA vaccine, like as if you are starting from the very beginning? So if this weird combination programmatically happens, so what does it for individual person in terms of effectiveness for the individual person?
Right. You know, we'll have a little bit we have examples, for example, where we give vaccines from different technologies and we mix them. So, for example, we give inactivated polio vaccine and then follow it by oral polio vaccine, which are different technologies, and there's no problem with it. So it's not an issue of safety at all. The question you may ask is whether you get a better response, or there are some arguing that when you mix them, you might even get a better response. It's not clear why, but this is a guess. But I would certainly say there's no reason to be concerned about that. If you want to mix, the companies usually say you should receive the same vaccine because that's their trial data is based on having the same vaccine. But in practice, again, you're basically stimulating the immune response, and there should be no reason why it shouldn't work. If you think about it, if you've been primed with one vaccine, it doesn't really matter what, if you get the antigen again, it almost doesn't matter in what form, you'll get an immune response to it. So why not? So I would see no reason why not. Again, I haven't seen any studies on this, but biologically, it doesn't seem to me to make any difference.
And the oncological patients, because recently in Ukraine, the oncological patients became priority for this immunization. But historically, they were not much vaccinated, even against influenza. And the oncologists themselves have lots of concerns and fears and hesitancy with regard to any type of vaccines, and including COVID vaccine. So there are a couple of questions. If oncological patients were vaccinated in Israel, and is it safe? Would you recommend it? And as well, I heard some recommendations from Ukrainian oncologists that even if you want to get vaccinated, then use the old-fashioned vaccines. But this new mRNA might make your cancer worse or provoke your cancer or something like that. Can you comment on that?
I haven't heard of any contraindication, and I know that we recommend the vaccine for oncology patients. And that's the mRNA, and I've not heard of any kind of contraindication or any reason why not. They may need more doses if they're being immune suppressed, and usually you don't give it at a time when they are being treated and they're immune suppressed. But I can't imagine any danger in using these vaccines. You need to consult with the hematologist. There may be situations where they would be hesitant during treatment. So some of the time, certainly during active treatment. And that's not, I don't think it's a danger. I just think it's a poor response to the vaccine. But I don't see it as being, at least as far as I know. And again, I haven't seen all the studies, but that's not seemed to be the recommendation. We vaccinate.
And people with the allergies who never had anaphylactic shocks but had allergies are concerned if they can be vaccinated or if they should take any anti-allergic drugs prior to getting vaccinated with any type of vaccines. Right. Were there recommendations like that in Israel?
No, and there's no evidence that people who are allergic have suffered any particular allergy. It's only if you are allergic to one of the components of the vaccine, and it's usually not so much the actual protein, the spike protein or the mRNA, it's the other components which are really preservatives and part of the production process. They're all products that are approved for human use generally, even used in foods and so on. So there's nothing toxic in the virus. In the virus, fluid that you inject. We don't seem to see any increase in side effects in people who have allergies. In other words, it doesn't seem to be. So if you have a food allergy or you have asthma and so on, that does not seem to be one of the reasons why people would have more side effects. But
and the big question is about the diabetes, because they have such a high risk in COVID, and at the same time, they are so scared to get vaccinated in Ukraine. Do you vaccinate people with diabetes in Israel, and how does it go?
Yeah, they're a high-risk group that are strongly recommended that they be vaccinated. People who have diabetes, who are obese, who have hypertension, they would be in the high priority groups.
And the last question of this interview, did you open any new course on COVID in your public health, in the university, in your program? And if yes, what is inside?
We did hold workshops. So what we did was, in my program, which I teach the international program in English, we had the students actually taking part in workshops where we would choose a topic in COVID. Could be a vaccine, it could be tracing, it could be vaccine passports, anything else. And the students would actually prepare the workshop. So we would give a talk. One of us would actually give a short talk, and then the students themselves would present. And we did something which was quite nice and worked well with the students. We actually gave them roles. So they would say, you are in a country X, and one is the prime minister, one is the minister of health, one is the minister of police, another is a physician in a clinic. And each one has to give their views on how they would deal with that particular situation. And it was very successful. The students felt that they learned a lot and they very much enjoyed it. And they did it very well. So I could recommend that for you. If you want me
Manfred,
to help you with that, I'll be happy to help with one of it.
Yes, I do.
Okay.
You spent more than 1 hour with us, and I am extremely grateful to you, knowing how busy you are. So thank you very much. I hope that since you're a fully vaccinated person, and if our situation improves, you will be allowed to come to Ukraine, because we definitely miss you very much in Ukraine. So thank you very much. And we expect you in Ukraine any moment when it will be possible for the vaccinated person.
Thank you, Katya. And I don't know if everybody knows, but I've spent a lot of time in Ukraine. My wife worked as head of the Office of World Health Organization for some years. And I love Ukraine. I love Kiev. I very much miss Ukraine. I miss the people. Great, wonderful. And so I hope to be back in Ukraine soon. Yeah.
And we hope to see you soon. Thank you very much again. And in this moment, we are going out of this program.
Thanks very much, Katya. And thanks to everybody who joined us. Have a good day.
Have a good day. Bye.